And go ahead. We're ready to go.
Excellent. Thank you all so much for joining this morning. We're very happy to be presenting. My name is Dr. Anthony Bunin with Behavioral Care Solutions. And you guys can all see these slides okay, I hope.
Yes, we can. We're good.
Excellent. I know today we're going to be discussing the upcoming CMS regulatory changes that are looking to be initiated the end of March, which present with some significant changes in terms of the nursing homes responsibilities with respect to psychoactive medication use. Uh, if you have questions, please shout them out. We're happy to answer any questions as we go along, but certainly we'll leave time at the end for further discussion. When we talk about the upcoming reg changes, I like to reiterate at the beginning it's not a change, but more a focus and reiteration on what the definition will be for psychotropic medications. As we know, CMS a year or two ago expanded what a psychotropic medication is considered to really expand it to any medication that has an impact on brain activity or mentation and behavior. Included in these classes are medications that we're used to understanding as psychoactives, antipsychotics, antidepressants, sedatives, hypnotics, anticonvulsants. Um, um, but we're expanded to include cognitive enhancing medications, so Aricept, Namenda, Exelon, similar types of meds, as well as herbal supplements and melatonin. So took a much broader definition of what is a psychoactive or psychotropic medication. With respect to these guideline changes, what we've seen is previously all medications were lumped under the F757, 758 guidelines, which pertain to unnecessary use of any type of medications. The upcoming changes pulled out psychotropic medications from this guidance and moved them under the F605 guideline, which is the chemical restraint guidelines, specific to psychotropics. Other medications are still under F757, 758. This was largely the move of any medication considered to be a psychotropic to the F605 chemical restraint guidelines. CMS really noted the purpose of that move was to streamline the survey process to really increase the consistency of how they survey and to strengthen the message that CMS is really focusing on, that any use of psychotropes or psychoactive medications should be the last resort for treatment. Uh, I want to point out that a big focus is specific to the use of psychotropic medications as it applies to managing behaviors in residents that have a diagnosis of dementia, and we're using medications to treat behavioral disturbances secondary to that primary diagnosis. Uh, so CMS is indicating that now they're training their survey teams to really focus on how these meds are being utilized and have provided more flexibility to surveyors uh, um, by moving these psychoactive meds under the F605, where they can move this to a level I or J tag, which we know is an immediate jeopardy tag. So it's giving folks more flexibility when they're surveying a facility to hand out these IJ tags, which we know carry significant civil penalties, daily fines. They can result in facilities banned from entering or having any folks admitted to the facility until that's cleared. Further, what they're training survey teams to really focus on is if we're using an antipsychotic medication that was originally prescribed for agitation or behaviors, uh, has this caused a significant change in the resident's quality of life, such that surveyors will be looking at the resident no longer is participating in activities they previously enjoyed. They're not able to carry on conversations or concentrate as they used to as a result of the meds, that they may be isolated more in their room throughout the day or sleeping. And that there's not ongoing adequate indication, GDRs, or other non pharmacological approaches to care that are clearly documented in the medical record. And if there's a resident that's unable to communicate verbally due to the extent of their dementia, that they have the ability, survey teams have the ability to look at psychosocial outcomes more subjectively for them to make a determination of how this may have impacted the individual's quality of life. And certainly that the medication is not being used for the sole purpose of discipline or staff convenience. So looking at these new guidelines, there was an update to the critical elements pathway that's included under Appendix PP of the new guidelines. We'll touch upon that at the end, and have provided a checklist to surveyors so that they have a clear way to identify misuse or use of meds for chemical restraints. In particular, again, we're looking at specific use of antipsychotics without residents that have a clear psychiatric diagnosis. While dementia is a psych diagnosis, it's also a medical diagnosis. So when we talk about a clear psychiatric diagnosis, we're talking about folks that have dementia but don't have a longer standing psych indication such as schizophrenia or other chronic psych diagnoses. Survey teams are going to be looking at the documentation in the medical record to ensure that there's been some attempts to provide non-pharmacological interventions before prescribing a psych med, particularly antipsychotics, and that they've been attempted prior to or in conjunction with the use of medications, and that it is easily inferred from the documentation and the medical record that these things have been attempted. And they're allowing surveyors more flexibility to interview medical directors or other prescribers in the nursing home setting regarding the pattern of their use of psychoactive meds. Moving forward, one of the focus items in the surveyor guideline updates is an increased focus on the PRN use of psychoactive meds or psychotropic meds. There is a 14-day limitation on all PRN orders for any type of psychoactive med. Pulling out antipsychotics outside of that class of meds, orders can be extended beyond that 14 days if the prescribing clinicians believe that it's appropriate to extend the order, documents clearly the clinical rationale for the extension, and provides a specific duration of use not to exceed 14 days. So there is the ability to extend those orders for medications other than antipsychotics. if we're using an antipsychotic on a PRN basis, you cannot merely extend the order. The clinician needs to directly examine the resident face to face or via tele, uh, merely speaking to the facility staff regarding how the individual is doing since the medication was started is not sufficient. It does require that evaluation by the prescriber, and then a new order needs to be written, not merely an extension of a previous order, and documentation indicates a clear clinical rationale for that new order, as well as the benefits of having that PRN medication in place over the past 14 days. When we look at behavioral issues specific to dementia and other conditions of a neurological nature, what CMS is indicating is that it does not mean we can't use medications during an acute or emergent situation on a PRN basis. What they're indicating is if somebody is experiencing an acute psychiatric condition or emergent situation where there be behaviors pose an immediate or imminent risk of harm to self or others, we're able to use medications to protect the safety of that individuals and others in the facilities. But we need to monitor those very closely and make sure that there's non-farm interventions also being attempted.
Amazing.
Um,
So,
when we look at medication use under these new guidelines, what CMS is indicating is, again, if we're using particularly antipsychotics or other classes of psychoactive meds, that the regulations are really focused more on these medications with respect to behavioral issues in individuals with a diagnosis of dementia, and that the focus is going to be reviewing the medical record to ensure documentation is sufficient. And again, looking at non-farm interventions being attempted, that behavioral tracking, which we'll briefly touch upon, is showing the benefits over time based on the use of those meds, uh, so that there is a clear ability to infer or to indicate in the medical record that there is some benefit. For conditions of a chronic psychiatric nature, such as schizophrenia, paranoid states, other chronic psych conditions where there is psychosis, we are able to use antipsychotics for an on-label purpose, such that the focus isn't so much on those types of diagnoses because those are consistent with the use of these classes of medications. It's really focused on the treatment of agitation or other distressing symptoms of dementia and using particularly antipsychotics as a short-term intervention to ensure the individual's safety and the safety of those around them. I'll pause real quick just to see if there's any questions, or we can continue and certainly open this up for additional discussion at the end. Excellent. We want to bring up the schizophrenia, CMS focused schizophrenia audits. Many of you may be familiar with this program as the diagnoses that were appropriate for the use of antipsychotics were limited under the 5-star rating system to schizophrenia, Tourette's, and Huntington's. There was a significant increase all of a sudden in the many nursing homes for individuals that suddenly had a diagnosis of schizophrenia that maybe sudden that at the age of 85 years old, somebody with dementia also now suddenly had a primary diagnosis of schizophrenia, and that allowed them to use antipsychotic meds without an impact on the facility's 5-star rating. Some facilities over 20%, from less than 1% prior to over 20% in some cases. So CMS launched targeted investigations for those facilities showing this significant increase in that type of diagnoses to ensure that there was clear documentation and supporting information to substantiate a schizophrenia diagnosis historically. So as a result, we're engaged in providing expanded reviews anytime we come across a schizophrenia diagnosis to make sure that the medical record clearly indicates the course and history that's consistent with the diagnostic criteria for schizophrenia, and not just a diagnosis that was added after an individual was admitted to a facility or coming from a hospital to a facility setting to substantiate the use of antipsychotics without penalty for the facility. With the focused schizophrenia audits, what we tend to see is there's little notice provided to the facility, unlike your typical surveys. So you may get notification on Monday and they're reviewing charts within a couple of days to look at folks that do have a schizophrenia diagnosis. So there needs to be a focus on that diagnosis in particular to ensure that it's accurate and that the medical record reflects the course and history that supports that diagnosis. A couple other points we always bring up is the use of anticonvulsants. I'm sure many facilities are now aware that if we're using anticonvulsant medications, which oftentimes are used from a psych standpoint as mood stabilizing medications, they now look at that as a potential high-risk medication. So anyone on an anticonvulsant, there needs to be an indication in the MDS under Section N. The reason for this is they want to now track the use of this med class to make sure that we're not seeing abuse of this type of medication. As antipsychotic use goes down, they're looking to make sure there's not a increase in the use of this class of medications to treat behaviors in dementia, since antipsychotics are now so much more regulated. Similarly, benzodiazepines, the use of benzodiazepines in the nursing home side, the guidelines have not changed. However, it's looking to limit the use of benzodiazepines further, again, similar to anticonvulsants, to make sure that we're not just starting to see an increase in other classes of medications, since we're not able to use antipsychotics or anticonvulsants as frequently. And they want to make sure that there is consistency with the existing guidelines in terms of should be used less than 6 months, shouldn't be used with opioids. And largely it's related to the fact that these are meds that do increase fall risks. The potential for addiction is greater, especially in individuals where there may be a history of substance abuse that's already in the medical record. So we have to be careful in how we use and track that. So the practical implications of these guideline changes is really more so about documenting medical necessity, making sure that there's gradual dose reduction considerations, which again stresses it doesn't mean we have to reduce a med. It's rather how we document the medical contraindication. Should it not be appropriate? If it is, there should be an attempt made. And then how we're monitoring specific side effects, such as abnormal movements, and that there should be more rigorous pharmacist, physician, prescriber reviews that are clearly indicated in the medical record, and that the use of the med can be easily inferred in terms of its value based on the medical record documentation, focusing more on training, educating staff at the facilities on different types of non-pharm interventions, dementia care, as well as these guidelines, and nursing staff clearly understanding when a medication qualifies as a chemical restraint, so that again, the burden of documentation falls on the facility and the clinicians prescribing to ensure that it's substantive enough to support the use of the meds. And again, higher risk of deficiencies and enforcement actions by survey teams that allow citations up to an IJ, immediate jeopardy level, or actual harm violation. So it's really giving survey teams much more flexibility by moving psychoactive or psychotropic meds under the F605 guidelines to handing out these type of tags. In terms of practical implications to the clinician that's prescribing, there's not significant language in the new guidelines that changes prescriptive patterns. It's really the increased burden of documentation that's the focus of these guideline changes, and the ability of survey teams to more readily and subjectively make a determination of impact on quality of life or use of psychoactives specific to chemical restraint purposes, and that surveyors have a greater ability to reach directly out to prescribers than they previously used to. So in terms of how do we improve compliance, it's really looking at what is the behavioral program that the facility has in place to really show that they've made efforts to develop a more robust program where there is an interdisciplinary team in place, that there are clear goals, coordination of care centered around behavioral issues, folks that do present with a specific diagnosis of dementia, that documentation is enhanced. Specifically, behavior tracking is occurring in a more focused fashion. I think many of us can agree that sometimes we may be using a specific medication for a behavioral issue, but when you look in the chart, the behavior tracking forms indicate either no information or zero, so it doesn't really line up. That there are IDT behavioral meetings going on, regular gradual dose reduction considerations, that the MDS is updated such that it's consistent, staff training is in place, family education, a greater focus on behavioral and activity planning and other non-pharm interventions. We want to make sure that there's stronger justification for use. So you can't just prescribe a psychoactive indefinitely without ongoing assessment. There needs to be a clear clinical rationale that's documented in the medical record, and that there's ongoing monitoring for adverse side effects, specifically with antipsychotics due to the movement disorders that can occur as a result of long-term use, as well as the black box warning that have clearly linked antipsychotics with an increased risk of stroke or mortality for individuals that present with dementia that are using them. Again, GDRs are occurring on a regular basis. If there's been a failed attempt, that it's been clearly documented. And there are exceptions for folks with more chronic psychiatric conditions as opposed to dementia with behaviors that need to be documented. And the focus would still require a GDR, but if there's been failed attempts or more clear medical contraindication, you'd still need to do that GDR on an annual basis. If we're using a psychoactive med, the indication for use should clearly be documented so that the behavior or mood indicators line up with the diagnosis, with the medication that's being utilized. Such that if we're using an antidepressant, there's clear behaviors that are indicated that line up with depression and so on. Real quick, we like to present this chart because it shows common types of medications we see in nursing facility settings. The second column showing what's the diagnosis or the indication for use that we may see in the EMR, such as with benzodiazepines, yelling or agitation. But now we need to have a more accurate indication for use that actually lines up more appropriately with that medication class. So instead of agitation or yelling, and we're using a benzodiazepine, anxiety, short term for insomnia, panic disorders, so on, Seroquel. Similarly, the indication for use needs to be better specified such that the diagnosis lines up with the medication that's being utilized and the symptoms that are being tracked are operationally indicated. Agitation is not a symptom per se. Agitation, it's a noun verb distinction. It's a global term. So we need to know, is it screaming, striking out, spitting, whatever the actual operational definition of that specific agitated behavior is. So we need to focus on a clear indication for use and making sure that we've ruled out any medical causes that may manifest in a psychiatric fashion. I think we all recognize delirium, especially in individuals with dementia, can oftentimes be hard to identify because delirium may cause confusion, but you're layering confusion onto somebody who's already confused. So sometimes the UA is our best friend. We just want to make sure that the medical record indicates those things have been ruled out. And then really looking at tracking behaviors. When do we need to really focus on behavior monitoring to when we're treating behaviors? When we use blood pressure meds, we take blood pressure readings after starting them to see the impact of that medication on that blood pressure reading. Similarly, if we're using meds to manage behaviors, we need to indicate what the behavior is, how we're tracking it, so that it's consistent in ongoing use of the med to support the cost benefit of using that med, that it's easily inferred during surveys so that people can see that. And it makes sense because without behavior tracking, it's very hard to change meds, increase meds. We always need to understand, is the medication working? We look at behavior tracking as an important aspect of how we identify particular triggers or cues that may be causing a behavior in the long-term care setting. Many behaviors don't just occur in a vacuum. If we look hard enough, we can find patterns within the behavior, times of day, certain situation. So understanding what's going on around the person when a behavior occurs, what time of day, where it may be happening, all that information can be pulled out of behavior tracking reports, even if it's simpler behavior tracking, just frequency reporting at the time of day specific to a behavior. I can't stress enough that merely indicating agitation is not sufficient. Agitation is not a behavior. We have to identify the specific behavior and track that so that we can find patterns, understand the efficacy of any interventions, whether it's psychoactive medications or other types of non-pharm interventions, and that everybody's tracking the same thing so that we can really understand efficacy and patterns that may be inherent in the presentation of behaviors. When we look at how we track behaviors, really, there's a couple different steps. It's recognizing what the behaviors are, assessing that, looking at identifying causes of behavior. Again, I can't stress it strongly enough. Most behaviors that we see don't just occur in a vacuum and go on for no reason. There really are many times patterns within um, um, how the behavior is occurring. Understanding the patterns really does allow us to develop better interventions to treat those behaviors, not just through meds, but through approach strategies and changing the cues and the triggers, and then how we monitor and follow up to assess the efficacy of what we're trying to do to manage the behaviors. Without tracking, it becomes very difficult for the prescriber to justify ongoing use of a medication, changes to a medication. And that's why, under these new guidelines, surveyors are really going to be looking at the behavior tracking process as well. Many simple tools to track behaviors. The easiest is frequency charting, and there's more advanced ways, what we call functional analysis tracking, that we can utilize as well and work with staff to complete a functional analysis when a behavior occurs, identifying what was going on before, what was the specific behavior, and then how did we react to that behaviors or others react, so that we can develop better behavioral management tracking and interventions. Oftentimes people are throwing around now the words of documenting non-pharm interventions, and oftentimes there's still some confusion about what does that exactly mean. Non-pharm interventions really are very broad strategies that can include activities and activity engagement, like sensory stimulation, how we structure routines in the long-term care setting. A lot of literature supports the more structure there is to the routines day to day in the facility, the less aggression or other types of agitated behavior we see in folks with dementia. Folks with dementia, due to their confusion, disorientation, really respond well to more structure. And then, of course, how are we using reward or reinforcement in a positive way to support positive or more appropriate behaviors? Oftentimes, until somebody engages in a negative behavior, because staff are very busy, attention or focus isn't given to that individual. Oftentimes that allows that behavior to then be maintained, supported, and it's harder to stop that behavior even through the use of medications, and then providing other types of therapeutic interventions, as well as family support. Sometimes families may be more difficult than the residents we work with and may inadvertently be involved in why a behavior is occurring. It may occur more frequently after family visits, things along those lines. So providing that family support. Again, the focus being how are we attempting to provide non-medication based interventions. So activities, sensory stim, those go a long way. I think we can all agree music, movement, those type of activities are universally calming, not just in a nursing home or long-term care setting, but in any type of setting and population. So how we structure these things becomes important, and how we document that in the medical record, and making sure that we're providing interventions and plans that are individualized to the to the resident specifically, how we're using praise, rewards, attention to encourage desired behavior, how we're structuring the environment to help manage behaviors that can promote more appropriate interaction and really reduce inappropriate or agitated or behaviors that may pose a danger to the self or other individuals in the facility, and again, routines. Uh, so there's many examples of behavioral interventions. These are just a few things. And we'll go into this further in part 2 when we look at more expanded discussion on behavioral and non-pharm interventions that are available. And then really when we look at considerations in non-pharm planning, in behavior planning, making sure that there's strong collaboration with the interdisciplinary team, the physicians, the staff at the facilities, families, so that there's clear, comprehensive intervention plans that are in place. Because of resident right issues, there's strong ethical considerations. Whenever we use the word behavioral planning, it really sort of conjures up these negative impressions that punishment is being utilized or something along those lines. What we're talking about always when we mention behavior planning is more about reward, reinforcers, not about punishment or taking away any resident rights that may limit their ability to engage in activities or that are restrictive or demeaning. And then, of course, how do we track things to make sure we understand the efficacy of what is being implemented and allowing us to make adjustments as needed in a real-time way, not just speculate as to what adjustments need to be made when we talk about non-pharm or behavioral interventions. The last point I'll make, and then we can open this up to discussion more, is understanding the critical elements care pathways. We're happy to provide a copy of Appendix PP in the 900-page guideline updates that CMS issued. But really what this pathway is specific to the behavioral and emotional status elements that CMS has identified, and surveyors are using this pathway checklist to determine if the facility is providing the necessary supports from a behavioral, emotional standpoint to the resident, and that it's person-centered in terms of the individual, it's not generic, and that these non-pharmacological care strategies are in place to meet the needs of the folks that we're caring for. And again, I do want to stress that there are situations where we need to use medications initially when there's an acute issue that goes on, an emergent issue where there is a clear danger to the individual themselves or to others around them as a result of this acute onset of behaviors, so that we need to manage that. I think most people that have joined this presentation would agree that sending folks to the ER has become largely an ineffective way of dealing with behaviors. Folks may go out, come back a couple hours later, and not much has been done. Many inpatient behavioral psych facilities sort of move away from working with individuals on an involuntary basis with a primary diagnosis of dementia, or they may indicate that this is situational in nature, the behavior, and therefore there's nothing they can do because the behavior is not being expressed at the ED or ER side or on the unit because it's specific to the setting that the individual resides, primarily, which is the nursing home. So we're happy to provide a full copy of Appendix PP of the new CMS guidelines so people can clearly identify what it is surveyors are looking at and assessing for. So wanted to provide this broad overview of these changes that are coming up here at the end of March and sort of open things up for questions at this point to get people's thoughts and any other discussion that you guys may feel relevant.
Yeah, feel free just to ask questions, unmute your line and ask questions. Add it to the chat box if you'd rather type it out. And again, if we don't have any questions, you can always email us at any point in time and we'll make sure that they get answered. Anyone have any questions? If not, then I think we are all set. Again, this is recorded, so we will save this and distribute this. Oh, it looks like somebody did have a question in the chat box. Once upon a time, I was told we do not need target behaviors for antidepressants. Can you confirm that?
Oh, in terms, historically, there was less focus on antidepressants, but because of the move to putting all psychotropics under the F605 guideline of chemical restraints, it's strongly encouraged that any psychotropic or psychoactive med is being tracked in terms of the specific symptoms that we're using that med for. So even an antidepressant, it's not just for depression. We should identify and be able to track the resident specific symptoms that we're using that med for. Are they manifesting depressive symptoms that would indicate isolation? So now we want to monitor how long is that person in their room. Are they crying all the time? That's a behavior we can monitor. Is their appetite impacted by the depression? So looking at appetite, any of those clear indications of what the specific manifestations were of that the depression with the individual, we should be able to identify and track to support the ongoing use of it. Otherwise, the question becomes, why are we using that med in the first place if they're not eating better or they're less isolated now as a result? They're sleeping better, whatever the specific case may be. So antidepressants, any medication now that's a psychotropic or psychoactive med, there should be the ability to track and identify the specific symptoms that are actually being treated.
Looks like we had another question come in. If you have recommendations for providers filling out GDRs when they are worried about it creating a poor outcome. It sounds like they had one of theirs having a GDR that went to psychiatric care due to the GDR, and how can they prevent that moving forward?
Right. And I think, well, there's sort of two elements to that question. Number one is a GDR, it doesn't necessarily mean that you must do a reduction in the medication. A GDR, a gradual dose reduction, it's a consideration for a reduction. If it's not appropriate to do the reduction, it's about how you indicate in the medical record the language to support that contraindication. And that really involves a couple of things. It involves an indication of the benefit of the med for that past period of time, so that it can be clearly demonstrated that using the med has been helpful, number one. Number two, that we're indicating that there's other non-pharm interventions that have been attempted and failed, that by withdrawing a medication, it would pose a potential or imminent risk of harm to self or others by withdrawing that medication, or they failed previous dose reduction attempts. So it's really all about how we document now. That's the focus. It's okay to use meds, but we don't want to see it impacting quality of life. But it's justifiable when the removal of meds would impact quality of life in a negative way and could create a situation where the person is presenting a higher imminent risk of harm to self or others. That answered the question. I don't know. Just want to make sure.
Thank you. It looks like we have Jessica asked, do you feel that routine Ames assessment is appropriate for all ongoing psychotropic medications or specific to only antipsychotic medications?
Oh, that's a great question. It's because Ames testing is indicated when we're using antipsychotic meds, because that's the class of meds that we can see tardive dyskinesia and other abnormal involuntary movements and syndromes that will develop. So it's really specific to the antipsychotic medications because of the nature of some of the side effects pertaining to movement disorders that can develop. So that's specific to the antipsychotics.
Does anyone else have any questions? Now's a great time to ask. Again, you can just unmute your line and ask them or type them in the chat box if anybody has any lingering questions right now. And if not, thank you so much for joining us today. Don't forget to come back on Thursday at 10 a.m. For the second part of this webinar series. And again, we'll be recording this and sharing this. And if something comes up, we have our experts at Behavioral Care Solutions that are happy to answer those questions for you and make sure that you stay compliant with these changes and updates. So thank you and have a wonderful day.